few. Okay. Hello, everyone. Welcome to this Facebook Live event through Riverside to discuss knee pain today. My name is Dr. Sandberg. I'm one of the orthopedic surgeons here at Riverside, and I specialize in total knee and total hip replacement at our hospital in Williamsburg. Hope all of you are staying safe in the pandemic out there. And we're going to talk about some things that we can do to address some of the knee pain that you may be having, especially if you haven't been able to get in to see any of us. We are open again to be able to address some of the pains that you have, and we're doing many extensive efforts to make sure that your visit to Riverside is as safe as possible. So without further ado, we're going to start talking about some causes of knee pain. There are many different causes. We're going to focus on one of the specific causes of knee pain that I deal primarily with, which is called osteoarthritis. So what is osteoarthritis? Think of osteoarthritis like a catch-all phrase that means inflammation or breakdown of the structures inside the joint. Now, in our knee joint specifically, we have two structures within the joint that are in between the bones that function like this car tire tread, and they take away some of the pressure from our bones. And this is a substance called cartilage. In the knee, we have two types. We have a slippery surface on the end of the bones called the articular, and then we have a thick disc of structure in between called the meniscus. Now, both of these can be prone to this wearing out. And this wearing out can look like little tears, little cracks, some thinning, and sometimes it can wear out all the way and actually expose the underlying bone. So the term osteoarthritis is really a catch-all phrase that means we're having breakdown of these cartilaginous structures in the joint, and then we have associated inflammation. And it also implies that we have some degree of pain and some motion loss, whether that's actual motion loss of the joint or just a subjective sense that the knee is stiff. It can be associated with this fluid on the knee, and this is what people think of when they hear the wear and tear arthritis. And I like this picture of the tire tread because I think that it demonstrates this pretty well. Now, on an x-ray, what this will look like is a narrowing of the space in between the bones. So right here, looking down on the kneecap, we can see that we have some narrowing of the space here. We can see some bone spurs, which are some remodeling phases that can occur once the bone doesn't have the protection from the cartilage anymore. And really, a lot of it is about the space and how much space is left in between the bones. So symptoms, as I mentioned, of osteoarthritis, pain is the predominant symptom that we have. Now, this can be in one spot around the knee, or it can be kind of globally in the front and the back. Typically, pain from arthritis doesn't radiate, meaning it doesn't go up or down the leg. It pretty much stays right in the knee. If you have pain going up or down the leg, up into your groin or the buttock region, that could be coming from another source. Arthritis pain, we also like to say, waxes and wanes, meaning that it may be worse in the morning, it may get better during the day, and then it may be a little worse again in the evening. Or you may have these flare-ups where the knee can be painful for 4 to 6 weeks, and then it may start calming down again on its own. The other thing about arthritis pain is it doesn't always match up with how severe your disease is or is not on the x-ray, meaning I see people all the time that have very poor looking x-rays and function rather well, and vice versa. So treatment is much more about you, the patient, and not you, the x-ray. Arthritis symptoms, though, are typically worse when you have impact activities, such as going up and down stairs, or running, or jogging, or jumping type activities. We mentioned stiffness before. This is a subjective feeling of poor movement. That symptom typically tends to be worse in the morning. And as I mentioned, it may progress to the point where the structures around the knee actually contract and you have actual motion loss. People also talk about a grinding sensation when they have arthritis. We again mentioned swelling or fluid inside the knee. And a common symptom that I hear from people is that they feel like their knee gives way on them. And I see a lot of people that come to see me thinking that maybe they've torn a ligament or they have some other acute injury like we would think of with an athlete. And a lot of time it's just a manifestation of the arthritis that causes that giving way. When we talk about treating arthritis, it's important to understand that there's no cure like we think of with other types of medical conditions, meaning I can't successfully regrow or replace the actual cartilage material or inject something to have things regrow the cartilage back to where it was. So our treatment goals for osteoarthritis then become giving you appropriate symptom management. And our main goal is to give you a way that you can maintain an acceptable quality of life. And since that means different things for different people, the treatment really is tailored to you, the person. And what may work and be acceptable for somebody's quality of life may be unacceptable to another person. So we have both non-operative and operative treatments that we can use to help you get feeling better on your knees. One of my favorite things to do for people that have knee arthritis is to recommend various forms of exercise. Walking can be a good exercise. However, if walking is one of the things that makes your pain worse, there are other things such as riding a bike, whether it's stationary or a mobile bike, or anything in the water that can be really helpful to help strengthen the muscles around the knee. It's a basic principle of arthritis of any joint that if the muscles around that joint are made stronger, the joint feels better. And so that's one thing that we try to highlight here. There are strengthening exercises that can be done at home. A lot of us find ourselves at home more. These are two of my favorites, especially the straight leg raise where you lay on your back, you straighten your leg all the way out and lift it about a foot off of the bed or the floor. And when you tighten up your thigh muscle, you hold it there for about 10 seconds before letting it down. I typically recommend this to almost anyone that comes to see me because I believe in this as a daily exercise. And I tell people if you make this part of your routine, like brushing your teeth, after 3-4 weeks of doing this, you will notice improvements of your pain. Now, does it improve it to the point you don't need anything else done? That's hard to say. Some people it does, some people it doesn't. But most everybody that does these exercises and sticks with them reports improvement of their pains. Other non-operative treatments of arthritis include what we call topical agents. So these are the patches, the creams, the gels, the ice, these compressive knee sleeves like the Tommy Copper sleeve that you may hear about. This doesn't actually change the disease, but it sort of creates a phenomenon where it gives the brain a different stimulus so that we aren't able to pay attention to the pain as much. And again, with our treatment of arthritis being focused on pain relief, it really doesn't matter what things help improve the pain as long as they're not doing additional damage, which none of these topical choices do. Oral medications can be very effective at improving osteoarthritis. So Tylenol is one that I'm a big fan of. Most people, unless you have a liver condition like cirrhosis or hepatitis, most people can take Tylenol, and it can be an effective pain reliever for osteoarthritis. It's important to understand that Tylenol works best, though, as a regular medicine. So the type of Tylenol that we usually take every once in a while if we had a headache really isn't the right dosage or frequency if you have more of a chronic condition like arthritis. So you can speak with your doctor about taking that on a more regular basis. Other medications to treat osteoarthritis are in what we call the anti-inflammatory regimen. These are things like the Advil, the ibuprofen, the Aleve. Those are the over-counter options for you. And then there are some anti-inflammatories that may be a little bit stronger that your doctor may be able to prescribe for you. And what's a really interesting thing that most people are not aware of is that if you're safe to take an anti-inflammatory, meaning if you don't have kidney problems or stomach upset when you take them, you can actually pair it with the Tylenol, and that can be a highly effective treatment for knee arthritis, especially if you're having a big flare-up. But with these things, we typically say you have to take them for about 2 to 3 weeks before you can really know if they've been effective at treating your pain or not. Injections are something that you may hear a lot about. The workhorse injection for osteoarthritis is what we call the corticosteroid. You may just simply hear this as a cortisone injection or a steroid injection. And what this is it's also an anti-inflammatory, but it's a much stronger anti-inflammatory. And with an injection, it allows us to put it right at the site of where all of the pain is coming from inside the knee. And now these can decrease the inflammation directly within the joint, and it can sometimes be very effective at helping the pain for several months. In general, there's not a lifetime limit on these. They are cheap and they can be effective. And if for you, this is something that works well to let you do the things you like to do, you can see a doctor and get an injection every 3 to 4 months indefinitely if you wish. The only downside of the injection is we don't recommend any surgical intervention like knee replacement for a period of at least 3 months afterwards, because it could increase your risk of the knee replacement getting infected. So let's talk about our surgical treatment. So total knee replacement, this is one of my favorite operations to perform. When it goes well for people, it can be a highly beneficial surgery to help improve people's function and their quality of life. When we talk about replacement, a lot of people think we're going in and cutting out large chunks of bone and replacing them. And really what we're doing is we're resurfacing the bones and giving them metal and plastic instead, which seems to help people's pain. It's important to know that a knee replacement is a replaced knee. It's not a new knee, which means that it may not feel exactly like the knee that you had when you were in your 20s. However, 85% of people that have knee replacements say it helps their pain, it helps their function, and that they would do it again. Pain improvement is the biggest thing that we see from replacement. Range of motion, if you have lost some motion in your knee before surgery, we can sometimes do some things to improve it. But if you have significant motion loss, your pain would improve, but the motion may not necessarily improve. As I mentioned, it's a resurfacing of the bone. So we take a saw during surgery and we shave off about 1 centimeter of bone from the lower part of the thigh bone and the top part of the shin bone. And then we replace it with these metal caps. And we have this highly specialized piece of plastic that fits in between that locks into the tray that is cemented into the shin bone. This is a picture of the knee replacement that I use, and we'll talk a little bit more about that in a moment. The implants are usually cemented to the bone. There's good longevity reported with cement. The benefit of it is you can get up and put weight on it right away. In select patients, we can do implants where the bone actually grows into the implant, and there is a thought that this provides perhaps more longevity to the implant. So in my practice, individuals that may be a little younger and have very good bone quality, this can sometimes be an option as well. But regardless of whether the knee replacement is cemented in or if it's uncemented, there still seems to be about a 95% survivorship, meaning 95% of the knees that we put in are still in and doing well 15 years out from surgery. Post-operatively, after knee replacement, this is an x-ray of a patient that was done here at Riverside that I did. We get you up and we get you moving and walking on this the day of surgery. So one of the things that we're really focused on here at Riverside is this rapid recovery protocol. So we have you up and walking the day of surgery. You typically just spend the one night with us in the hospital, and most people return back to their homes. And we take a lot of pride in getting most people back to their homes after their joint replacements because we think that people do better there. You have home physical therapy for the first 2 to 4 weeks after your surgery, and then we transition you to outpatient physical therapy after that. Now, it's important to know that knee replacement is painful to get over. It's just a painful and hard surgery sometimes for those first few weeks. But if we know that going in and we think of it as an investment, as the weeks go on, people then start to report significant improvements in their pain and their function. And it's about week 6 that I see most people saying that they're glad that they did it and they're already improved from their preoperative state. Now, that being said, we know that people continue to improve after knee replacement for a full year after surgery. So everybody recovers at kind of their own rate. And so if you have knee replacement, it's important to pay attention to how you recover and not worry as much about if you're keeping up or you're ahead of somebody else that you know that had replacement. Everybody will recover at their own rate. I mentioned that we do all of our knee and hip replacements at the Doctors Hospital up in Williamsburg. We've taken great efforts to create a system up there that we have a multidisciplinary approach where the physical therapists, myself, the hospitalist team, the anesthesia team, the implant representatives, the pharmacists, everybody that's involved in your care meets on a weekly basis to discuss the upcoming needs of the patients that week so that we can anticipate things that might either delay your care or additional needs that we may have so that we can make sure that we deliver the highest quality joint replacement to you as possible. The hospital up there being a little bit smaller also gives us more ability to have control over the process of sterilizing the instruments and making sure that we have a consistent team that works with us up there. I mentioned also the knee replacement that I use is a knee replacement called by a company called DJO. It's called this Empower 3D knee. It's important to know that knee replacements in general all do well. There is that 15% or so of people that may not be satisfied. And so every company has sort of their answer to it. I like this knee because it was designed to more closely replicate the normal mechanics and what we call the kinematics of the knee. Anecdotally, I think people do very well with it. There have been some early studies that suggest maybe we lessen that 15% of people that are dissatisfied, but it's still early in the data to know for sure. But I definitely think it is a stable knee that can do well for you, like most knee replacements, but it's something that I'm proud of that we use here. And with that, we can take any of the questions that you may have.
Doctor, the first question we received from our live stream today was with reference to stem cell therapy. Can you address stem cell therapy maybe as it relates to knee arthritis?
Absolutely. So stem cell therapy, I would say, so those that have come to see me know that I try to be as honest as possible. And my honest answer is there is not a lot of science to back the marketing claims that you hear. The stem cell therapy is very expensive. It's an interesting thought process, but by and large, what most individuals that are selling stem cell therapy are selling, I think, are false hopes. The thought that if you have a completely worn out joint where there's no cartilage left at all, that you have an injection with stem cells and it will regrow all of that cartilage. The science is just not there, and the American Academy of Orthopedic Surgeons currently does not recommend stem cell treatments as a treatment of osteoarthritis.
Thank you. The next question we received is, how long will my total knee replacement take for recovery process? And what signs of progress do I look for after a total knee replacement?
So these are both good questions, and I would say these are highly individualized. As we know, people continue to recover for a full year. We know that your most rapid recovery happens in the first 3 months. I would say to a certain extent, it depends on how you define recovery. As I mentioned, you'll be up and walking on it the day of surgery. If you're defining recovery as your return to work, I tell people if you have a desk job, you can most likely return to work by about 6 weeks. I tell people if you have a heavy duty manual labor job, like you're a brick mason, you may need as much as 10 or 12 weeks before you're able to get back to full duty of going up and down stairs, lifting heavy loads. And if you're somewhere in between, then it's somewhere in between. Things that you should look for pain to be continuing to improve, I would say on about a week to week basis. And I think that you should be looking for your motion to be improving as well on a week to week basis.
And then the last question we received was, how soon can I start playing sports, biking, golfing, those sort of activities?
Another good question that I hear a lot. So in terms of golfing, chipping and putting, usually I let people start resuming if everything's been going well from their knee replacement at about week 8 to 10. I like to have people about 4 months before they're really opening up and really cranking on a driver. Biking can begin much sooner than that. As soon as you have the range of motion that really you can get that pedal all the way around, I have no problem with people getting back on the bike as soon as their motion and their pain allows.
Great. Dr. Sandberg, thank you so much for joining us today. And we look forward to our upcoming Doc Talk Lives. Thank you so much. And for all of the viewers, we appreciate you taking time to join us.
Thank you.